Hi there. Thanks for tuning in. I'm Kevin Schwartz. I'm an infectious disease physician here in Toronto. I work at St. Joseph's Health Centre at Unity Health Toronto, Public Health Ontario, and University of Toronto. I'm very pleased to present on this pragmatic trial titled Mailed Feedback to Primary Care Physicians on Antibiotic Prescribing for Patients aged 65 years and older, Pragmatic Factorial Randomized Controlled Trial. And the study was recently published in the BMJ, which you can find there at that link. I don't have any conflicts or disclosures. And just as background for this work, antimicrobial resistance is an important emerging public health threat. From a recent study, there are 1.14 million deaths attributable to antimicrobial resistance in 2021, and antibiotic overuse is an important contributor to rising rates of antimicrobial resistance. Unnecessary antibiotic prescribing is also very common in primary care, an important target for reduction. From previous work that we did, about 25% of antibiotics in primary care practices in Ontario are likely unnecessary. We know that more antibiotic prescribing is associated with more unnecessary prescribing, so important to make sure that we reach the highest antibiotic prescribers. And another area for improvement is we know about 1/3 of antibiotic prescriptions are for greater than 7 days, and we know that most prescriptions should be 7 days or less in primary care for most common infections. Audit and feedback is a strategy that can work to reduce antibiotic use. So we wanted to look at audit and feedback across the population of Ontario, and we also wanted to look at ways to see if we could improve the way that we do audit and feedback. And what informed our design of this study was a couple features. One is the way that physicians often respond to audit and feedback, where they can sometimes reject the data with the rationale that their patients are different. They don't feel like the data properly captures their unique practice characteristics or patient populations. The other aspect is related to antibiotic prescribing and this imbalance of risk. Physicians often say in qualitative work that they feel that while they don't think antibiotics are necessary in all these scenarios, they often prescribe them just to be safe and worried about bad consequences for the patients, when in reality, the harms of unnecessary prescribing are actually greater than the possible benefits where in these conditions where they're not necessary. So with that, our research question was, does providing family physicians with feedback on their antibiotic prescribing using routinely collected data compared to their peers reduce antibiotic use? And that was the primary research question. We also embedded additional questions on, can we achieve further incremental reductions in antibiotic prescribing by providing case mix adjustment in the feedback reports to try and address that first issue that I mentioned about not reflecting their unique patient populations. The second change was emphasizing antibiotic-associated harms to address this tendency to underestimate antibiotic harms. And the way that we did this was as a pragmatic randomized controlled trial of a mailed audit and feedback report compared to no report. And we did that in a randomized fashion in a 4-to-1 ratio. And then within that intervention group, we embedded a 2-by-2 factorial trial to test those other interventions. We did this across Ontario in Canada. One limitation to our data is that we only have complete prescribing data for patients that are 65 and older, and so the data is limited to that population in Ontario. We enrolled all family doctors who are not already signed up to receive antibiotic prescribing feedback. There is something that's called My Practice reports done through Ontario Health. This is a voluntary program of audit and feedback that has a number of metrics in it, but includes antibiotics, and physicians can voluntarily sign up and log in and receive that data. So we excluded those docs from this intervention. We also excluded low volume docs or ones that don't prescribe antibiotics to patients that are 65 and older. We sent a single letter out to the intervention group in January 2022, and then we repeated the exact same letter about a month later to try and increase attention to it. The analysis was done through Poisson regression models with the outcome of antibiotic prescribing rate, and we adjusted for a number of factors in the model, including their baseline prescribing rate, physician sex, years in practice, as well as whether or not they were enrolled in a previous trial we did in 2018 that was limited to high antibiotic prescribers. And then in these models, we added the presence or absence of the other factors of the different design features to do the factorial trial component. This is our consort diagram, and so there's over 15,000 family physicians in Ontario. Many thousands of them are not active and they were removed or they didn't meet our inclusion criteria. There's about 9,000 then eligible active family doctors, and we removed another about 2,500 of those who are already signed up for feedback. Of the just over 6,000 doctors, 1,000 were not linkable for various reasons or incorrect address or CPSO number. And then we had just over 5,000. We sent an opt-out letter to all of those doctors, giving them the opportunity to opt out of the trial. Less than 5% of docs did or had a return to sender because of invalid address at that point, and they were removed. And then we had just over 5,000 that were randomized. As I mentioned, the 4-to-1 ratio with that embedded factorial trial, and that intervention was randomized at equal groups of 1-to-1 to 1-to-1. Just very briefly, this is what the intervention looked like. So it was a mailed personalized feedback report. This is the adjusted data letter. So what you see is on the first page, there is a central figure that draws attention to why they're receiving this letter and has some messaging about what to do with it. In this letter, we sort of tried to highlight all over that these are adjusted data. They're compared to physicians that are similar to theirs. We sort of highlight on the front page what we used in the modeling in terms of all these patient practice factors. Compared to the unadjusted front page of the letter, it doesn't have any of that wording or messaging related to adjustment, and it just says they're compared to other family doctors in Ontario. The harms factor was on page 2 of the letter, where we have this infographic and wording are related to the harms of antibiotic use, side effects, antimicrobial resistance. The non-harms group received this infographic that doesn't have any of that messaging related to harms, only about the lack of benefits of antibiotics. The rest of the letter was the same and consistent amongst all the groups. It really has just evidence-based strategies to try and improve antibiotic prescribing, and it's co-signed by a variety of authority figures or colleagues from Ontario. So these are the results of the trial. This is the overall result for the primary question of intervention versus control, just as monthly antibiotic prescribing rates crudely presented. And what you can see is the interventions done early 2022, and we start to see some separation between the intervention group, which is in yellow, and the control group of physicians who did not receive a letter. These are the primary results from the models of the study. So just to highlight, for the primary outcome of overall antibiotic prescribing rate, there was about a 5% relative reduction that was statistically significant. We looked at a number of other antibiotic outcomes as well, including unnecessary antibiotics or prolonged duration antibiotics or broad spectrum antibiotics, and all were statistically significant reductions in those outcomes. We did not find, however, any significant reductions for the factorial trial component. So the case mix adjusted versus standard feedback, we actually saw small, about 1%, but statistically significant increase in prescribing for physicians that received the adjusted data. And for the harms messaging, we saw no statistically significant changes in their antibiotic prescribing between those letter groups. We had a number of pre-specified stratified analyses that overall the results are fairly consistent amongst the different groups that we looked at for the intervention versus control for the primary outcome. One interesting one was that baseline antibiotic prescribing rate was statistically significantly different between groups, with the highest antibiotic prescribing physicians at baseline being the most likely to respond to the feedback, which is really what we were hoping to see, as these are the doctors that we believe and have shown are prescribing the most unnecessary antibiotics. We did some fidelity assessments within the trial where we made random phone calls to 135 physicians up to 2 times just to see if they had opened the letter. It was actually quite difficult to reach most physicians, so more than half could not be reached despite 2 attempts. About 30% were reached and did not open the letter, and only about 13% of the docs we contacted could confirm that they opened to and remember receiving the letter. This trial has some limitations. It was implemented just post-COVID, where antibiotic prescribing was very different. It had actually gone down quite a bit with the lack of respiratory infections during that time and was rising quite rapidly at the time of the intervention, which sort of highlighted the importance of the randomization component, or it would be very difficult to see any impact. We excluded MDs that were already interested in feedback, but we feel this makes this pragmatic trial very generalizable to a relatively unengaged group of physicians. I would just sort of caution the interpretation from the factorial trial. We didn't specifically power for that component. It was more of a secondary analysis, and we didn't control for contamination between arms. So it's possible physicians within the same practice got variations of the letter. Data are also limited to patients that are 65 and older based on the data limitations in Ontario. So this is our visual abstract, just highlighting the impact of the trial and the significant reductions in overall antibiotic use we see from a mailed audit and feedback letter. So just to summarize, we saw significant reductions in both total and specifically unnecessary antibiotic prescribing across 5,000 Ontario physicians enrolled in this trial. The intervention modifications were unsuccessful. We have a couple of theories, and we've done some qualitative work that we have published that try and explain why we saw those findings. So one theory is that giving these doctors adjusted data paradoxically reinforced the cognitive bias that we were trying to address. We know docs feel that sometimes the data doesn't account for their patient populations, and maybe the way that we did it, or just by drawing all their attention to their patient differences, it reinforced that cognitive bias. It actually made them less likely to respond to the data. Some physicians did not notice or identify the adjusted data, but so for a variety of reasons that did not work. The harms messaging also was not probably new or provocative enough to institute a change for physicians to address that sort of underestimation of antibiotic harms. We do think that antibiotic audit and feedback should be a routine expectation in primary care. We feel this is scalable, it's cost effective, it works, and really should be more widely implemented. We do need more research on a couple things related to this, such as improving engagement. How do we get doctors to read and open and attend to this? And we obviously can't have as big of an impact if they're not opening it. And co-interventions. So these are small impacts on antibiotic prescribing, but it's scalable. But what else can we do in antimicrobial stewardship that are going to make a bigger impact in the long term? Just want to thank that we have a very large team and a lot of partners involved in this trial. And thank you very much for your attention.